Hello, and it's really an honor and a privilege to be able to speak to you at the OB Neuro Conference today. I'm Cheryl Bushnell. I'm professor and vice chair of neurology and stroke section chief at Wake Forest Baptist Medical Center. And it's really, as I said, an honor to be here. These are my disclosures. I have research salary support from PCORI, AHRQ, and NIH, NINDS, and ownership and care directions, but none of these are relevant to the current topic. So my objectives for the next 30 minutes are to discuss the incidence and risk factors of ischemic stroke and hemorrhagic stroke in pregnancy, and I'll sort of also cover cerebral venous sinus thrombosis and split those two topics. I'll also try to look at the different stroke types and provide some case examples. And then I'll describe some of the management strategies for ischemic and hemorrhagic stroke, as well as cerebral venous sinus thrombosis. So the incidence of ischemic stroke or stroke in general in pregnancy varies widely from study to study, and this is a systematic review and meta-analysis of 11 different studies from all over the world, and you can see that the effect estimates vary quite a bit, but the pooled estimate puts it right around 30 per 100,000 deliveries. And this table here shows you the different stroke types and how they are distributed amongst women who might have stroke during pregnancy. So about 9 per 100,000 for cerebral venous sinus thrombosis, 12 each for ischemic and hemorrhagic stroke. And then the timing tends to be more often antepartum, but really the majority of these are probably peripartum. So right around delivery is a very common time for stroke to happen. And then postpartum also quite common at 14.7 per 100,000 deliveries. Now, one of the unfortunate things is that the incidence and the prevalence of postpartum hospitalizations and all pregnancy-related hospitalizations is increasing. And this is a study from the nationwide inpatient sample comparing the years of 94 and 95 to 2006, 2007. And the rate of any stroke increased 47%, and the postpartum hospitalizations increased by 83%. And you can see this is for all of the stroke subtypes. So this is alarming, and the interesting thing about the analysis here from the nationwide inpatient sample is that they saw an increase, corresponding increase with both heart disease and hypertension. So presumably there is a relationship between those diagnoses increasing as well as pregnancy-related stroke. So one of the things that's important to recognize is that cerebral venous sinus thrombosis is much more common in pregnant women than non-pregnant women. And when you look at the non-pregnancy strokes in all age groups, you can see that cerebral venous sinus thrombosis is really just a very tiny fraction here, about 1%. And then hemorrhagic strokes would be about 15%, and ischemic would be 85%. But here in pregnancy, you can see that there's somewhat of an equal distribution amongst all three types, as I mentioned earlier in the slide with the table. So this is a major difference to think about when you're looking at women who might have a stroke during pregnancy. Is it almost as likely that they're going to have cerebral venous sinus thrombosis, hemorrhagic, and ischemic strokes. So this is a characteristic imaging from CVST, and you can see that the signs and symptoms are really less often focal symptoms and more often headache, seizures, and increased intracranial pressure. And all of those things can lead to some of the hemorrhagic complications that we see. So here is a CT showing you the spontaneous hyperdensity of the right transverse sinus. And here is a digital angiogram, subtraction angiogram showing you a superior sinus superior sagittal sinus thrombosis here, showing you the clot and the lack of flow. So all of these things can lead to a backlog of blood that leads to a venous infarct, and then because of the low pressure system, a high likelihood of the venous infarct leading to a hemorrhagic transformation. Some of the causes and risk factors of pregnancy-related stroke to really emphasize are the importance of age and race ethnicity. This was a nationwide inpatient sample analysis that my colleague Andrew James and I did back in 2005. And you can see here the tremendous difference in stroke rate and the odds ratio associated with age 35 to 39 compared to women who are less than 20. Over the age of 40, you have an even higher spike in rate, up to 90 per 100,000, and a threefold increase compared to those under 20. And then African American women have a much higher rate than white women, about a 50% higher rate. Over the age of 35, white women compared to other white women had a twofold increase. And then African Americans, even under the age of 35, had this 50% increase. And then over the age of 35, a 4.5-fold increase. So very important to take into account age and race ethnicity. Some of the causes I've put lumped them together and used different color font to represent the fact that they are somewhat related. So of the vasculopathies, you have reversible cerebral vasoconstriction syndrome, posterior reversible encephalopathy syndrome, or PRES, and Moyamoya disease, as well as either carotid or vertebral dissection. And then some of the embolic disorders, particularly cardioembolic here, postpartum cardiomyopathy, valvular disorders, other cardioembolic causes such as patent foramen-ovale, and congenital heart disorders, as well as amniotic fluid embolism, which is very rare, but is an embolic phenomenon that could happen during pregnancy. And then thrombophilias or coagulopathies are also likely to cause ischemic stroke. And then you have preeclampsia, eclampsia, and HELP syndrome, all of which increase the likelihood of hemorrhagic more than ischemic stroke, and then cerebral aneurysm and arteriovenous malformation, again, leading to subarachnoid hemorrhage. In terms of hypercoagulability, there are many changes that happen during pregnancy that are described in this table. So factor 1 and 2 and 5, 8, 7, 8 all increase throughout pregnancy. And you can see some of them increase early and then decrease again. And then factor 10 increases, factor 11 decreases, 12 and 13 increase, and then protein S decreases throughout pregnancy. Activated protein C resistance increases, leading to a decrease in protein C activity. I'll just mention here that protein S is known to be really difficult to interpret if you happen to order it in a pregnant woman. So I would recommend not investigating this as a cause of stroke-related pregnancy, especially if the woman is still pregnant or postpartum. So I'll start with one case to illustrate some of the risk factors and causes that I've just discussed. So this was a 35-year-old woman that we took care of at Wake Forest. She had a history of preeclampsia and a vaginal delivery, and at that time she was 3 weeks postpartum. She had acute onset of slurred speech and right-sided weakness. Her initial NIH stroke scale was 17. She didn't have any acute hemorrhage, no large vessel cutoff. Her blood pressure was fine at the time, and she was a candidate for TPA, so she received thrombolysis. She was also started on magnesium for possible postpartum preeclampsia. Her workup showed these multifocal acute and subacute infarcts. You can see here located in a variety of different vascular territories, here in the brainstem area, posterior circulation, also here in the thalamus and here in the left frontal cortex. And investigation with transthoracic echocardiogram showed that she had a severely dilated left and right ventricle and an EF of 15 to 20% with a left ventricular thrombus. So unfortunately, this woman had peripartum cardiomyopathy, which is the development of symptomatic heart failure in the last month of pregnancy or within 5 months of delivery. There also has to be no other identifiable cause of heart failure and the absence of a pre-existing heart disease prior to the last month of pregnancy. And typically the left ventricular EF is less than 45% in these women. And so all of those things need to be true in order to make the diagnosis. And unfortunately, there is a relationship between peripartum cardiomyopathy and preeclampsia. And so this woman, unfortunately, had all of those things together. And then I'll talk now about hemorrhagic stroke during pregnancy and cover in a little more detail these common causes, which is preeclampsia, eclampsia, and HELP syndrome, as well as cover the subarachnoid hemorrhage that occurs as a result of aneurysm and AVM. So this case is a healthy 24-year-old woman at the time of her first pregnancy. She delivered a healthy baby boy. This was back in 2011 by cesarean section. At 12 days of delivery, she developed severe hypertension, blurred vision, right leg weakness, and then had the onset of a seizure. Her MRI brain showed 2 separate hemorrhages and evidence of severe hypertension. And I saw her about 3 or 4 years later as a result of ongoing partial seizures, which I surmised was happening as a result of the event that occurred during pregnancy, or postpartum, I should say. So this is her MRI scan done at the time of her event, and it showed 2 separate hemorrhages. And you can see that the flare sequence shows this the best. And this was consistent with PRES, or posterior reversible encephalopathy syndrome. And just to show you the different vasculopathies that are associated with preeclampsia, eclampsia. So here is PRES, another example from a different patient in the literature, showing multiple areas of these white matter changes. And what this is really vasogenic edema, the sudden elevations in blood pressure that exceed the cerebrovascular autoregulatory capacity. And the result is this vasogenic edema. In contrast, you have reversible cerebral vasoconstriction syndrome, which can also happen as a result of pregnancy. This is more commonly had been called postpartum angiopathy. And so this is much more likely to happen postpartum. It's associated with a severe thunderclap headache that comes on very, very quickly. And it's characterized by the diffuse or multifocal segmental narrowing that you can see with MRA, CTA, or standard angiogram. And this can actually lead to ischemic stroke and cytotoxic edema as a result of the severe vasoconstriction. So those are the 2 different vasculopathies that are associated with preeclampsia or eclampsia. And in fact, they can actually happen in the same patient. So going back to the case that I just discussed, case 2, the woman with PRES and eclampsia, postpartum eclampsia. One of the things that came up as she was, a few years out from her event was what kind of oral contraceptives are safe. She developed ovarian cysts, and her OBGYN was really concerned about prescribing oral contraceptives. And so prior to doing this, they wanted to talk to me and say, well, she had this event, she had a hemorrhage, is it okay to actually prescribe contraceptives? And in this situation, what I would recommend is to assess her cardiovascular risk factors, use the lowest dose estrogen, and if there's a thrombophilia, really try to avoid estrogen altogether if possible, or you could consider an IUD or progestin-only options. And this woman did have really painful ovarian cysts that were best treated with low-dose oral contraceptives. So the risk of preeclampsia, eclampsia is elevated with subsequent pregnancies. And this was shown in a study from 2010 that recurrent preeclampsia occurs in about 16% of these women. It may depend on their inter-pregnancy weight gain, as it turns out. And this woman did get pregnant again, and she did end up with preeclampsia, which was not as severe and not associated with another stroke, thankfully. And so that was a problem. In addition to her seizures, she had to be on antiepileptics, and that was a challenge during her pregnancy because of the changes in physiology and epilepsy anti-epileptic drug levels for her. So that was another thing that she had to contend with. And then there is the risk of developing other risk factors, and particularly hypertension. There's a 4 to 10-fold risk of hypertension after hypertensive disorders in pregnancies. And this may plateau in some women. And then the risk of stroke is increased. It ranges from 1.7 to 3.8-fold increase in women with preeclampsia compared to women who have not had preeclampsia. So there's a lot of downstream consequences of developing this complication during pregnancy. So what is the epidemiology of intracerebral hemorrhage during pregnancy and postpartum? Over 50% of strokes during pregnancy and postpartum are hemorrhagic, and subarachnoid hemorrhage and ICH are more common in pregnant than non-pregnant women of childbearing age. So I think this is another really important epidemiologic statistic to keep in mind. The risk factors for hemorrhage in particular are, of course, hypertensive disorders of pregnancy, which include preeclampsia, coagulopathy, maternal age older than 35 years, African American race, ethnicity, and tobacco use. So those are all things, many of them, the tobacco use and the hypertensive disorder of pregnancy, and maybe even the coagulopathy, are things that could be recognized prior to getting pregnant. So I show you here an MRI T2 weighted sequence that shows this aneurysm here in the left MCA. Here again is an arteriogram showing you the aneurysm, and here's an even larger one shown here. So this is what they can look like, and these are ones that are probably more likely to rupture because of the size and the shape. So greater than 6 millimeters is a significant size. Here is an arteriovenous malformation based out of the left carotid artery. And so this is obviously very large and more likely has already bled or has a high likelihood of bleeding. So how do you manage aneurysms and AVMs during pregnancy? Well, an unruptured aneurysm rarely does rupture during pregnancy. And so the likelihood of that happening is 0.001 to 0.01%, or 1 to 10 per 100,000 pregnancies. Most of the ruptures occur antepartum, and many of those are in the 3rd trimester. And as I said earlier, if they're greater than 6 millimeters, they're much more likely to rupture during pregnancy. So monitoring is recommended, especially in the 3rd trimester, but if they're stable, there's probably no surgical treatment that's needed and they could deliver normally. Surgical management of ruptured aneurysms, God forbid that happens during pregnancy. Outcomes are much better if they are managed surgically, and that the endovascular management is superior to an open surgical clipping. So in terms of AVMs, pregnancy increases the risk of bleeding from AVMs. And if an AVM has previously bled in a woman planning to get pregnant, it's probably best to go ahead and electively treat it prior to getting pregnant. And then in this case, Of course, it's quite rare, but surgical treatment of ruptured ruptured AVMs during pregnancy is unclear. So whether it improves outcomes or not, it's still an unknown. So for these women, it probably is on a case-by-case basis as to how they should be treated. And of course, you need your neighborhood neurosurgeon with experience in this in order to be able to manage them. So ischemic stroke during pregnancy, we have some options. There's the option of thrombolysis with alteplase or tenecteplase, and then clot retrieval. There was a lot of controversy with thrombolysis initially. The animal studies showed no evidence of teratogenicity, but of course, none of the randomized controlled trials testing alteplase have included pregnant women. There are case reports and small case series, and they've looked at outcomes in both mothers and babies. And generally, most women do well. Of course, there have been some who've bled and some babies who've had worse outcomes. But in general, it's thought that alteplase does not cross the placenta, so it really should not pose a direct intracranial or systemic bleeding risk to the baby. However, you know, a lot of these strokes could happen in the postpartum period, and the safety and efficacy of the IV alteplase within that short time frame of 14 days after delivery has really not been well established. So it's still a case-by-case basis, I think, in terms of what to do during that time frame. So the Canadian Stroke Best Practices Consensus Statement is a really useful resource if you're trying to figure out how to develop a strategy for treating these women. And this is a direct quote from that publication in 2018, saying that it is reasonable to consider giving IV alteplase to a pregnant woman with disabling ischemic stroke who meets the existing criteria for thrombolysis. And the risk-benefit considerations can be complex. However, the decision should be undertaken in consultation with a physician with experience in acute stroke treatment, either in person or through telestroke modalities. And so I think that's really the bottom line, is having somebody with acute stroke experience, and even better, someone who's got experience with working with pregnant women. So here is case 3. This is a 33-year-old woman who was 34 weeks pregnant, had acute onset of aphasia, right-sided weakness, and neglect. She was found by her family with a last known normal of over 5 hours. Her initial NIH stroke scale was 24, so she had some really quite severe deficits. Her CT of the brain was negative for blood. And so the question at this point is whether she is a candidate for endovascular clot removal. And clearly the answer is yes, because this is a disabling stroke, and she is outside the window for thrombolysis at 5 hours. Now, the other thing we look for to determine if someone is eligible for thrombectomy is whether they have the imaging that is favorable for saving the majority of brain possible. So here is a CT angiogram showing you the left M1 cutoff, and then here you have the evidence of a very small core and a very large penumbra. Now, I will say that there is controversy about using these perfusion metrics within 6 hours, because none of the endovascular thrombectomy trials used this type of rapid imaging software in under 6 hours. So again, just to take that into account. But between 6 and 24 hours is when we tend to use perfusion results to help guide our therapy. Otherwise, if you have a CTA showing this large vessel occlusion, and they meet all the other criteria for thrombectomy, then they should go right to the IR suite. So this is just showing you a little bit about the technology that's commonly used in the stent retriever category. It's in the catheter here. The catheter goes through the clot. The retriever is expanded. It goes into the clot and up against the wall, and then it is pulled back, and the clot comes out nicely with it. So here you can see the clot sitting in the MCA. This is the M1 occlusion, and this is the after angiogram showing you restoration of flow into that MCA territory in the AP view. So this is obviously a technique that can be very, very effective in women who have a large vessel occlusion and happen to also be pregnant. So the Canadian Stroke Best Practice Consensus again says, get rapid brain and vascular imaging, rule out a preeclampsia versus arterial occlusion versus other vasculopathies, understand the risks of endovascular treatment, which does include radiation and contrast exposure, and that those are hopefully outweighed by the after effects of not treating a large vessel occlusion, which in the case I showed you would have been devastating to that woman who is young and still, a young mother, really. And so for women with large vessel occlusion who are eligible for endovascular thrombectomy, it may be reasonable to proceed directly to this treatment without IV alteplase, even if it's under 3 hours. It depends on the timing of the onset, but it is reasonable to consider going directly to the IR suite and removing the clot. So cerebral venous sinus thrombosis is tricky because in severe cases, you may have a moderate hemorrhagic infarct. As I said earlier, you have congestion of blood from the venous backflow, and this can lead to pretty significant hemorrhage. But treatment with anticoagulation is still recommended because it reduces the pressure associated with the sinus clot, and that is the underlying cause of the bleeding because of that venous congestion. Now, increasingly, endovascular thrombolysis and clot retrieval is being used as an option. But right now, there is no evidence to say that this is the best treatment. It has not been tested in clinical trials. It may be best for severe cases or when there's some case where anticoagulation is absolutely contraindicated. So summary and take home, the incidence of stroke during pregnancy is about 30 per 100,000 deliveries. And as I said, it's increasing along with the risk factors of hypertension and heart disease. And you're likely to see a somewhat equal distribution of cerebral venous sinus thrombosis, ischemic, and hemorrhagic stroke. Preeclampsia, eclampsia is an important cause of hemorrhagic stroke, but also increases the risk after pregnancy and childbearing. Thrombolysis and endovascular thrombectomy are options, really can be life-saving for pregnancy-related strokes and reducing really severe disabling strokes. And then it's really important to have collaboration between vascular neurology, neurocritical care, neurosurgery, and OB for making these treatment decisions, and of course the family and the patient. But all of these things related to thrombolysis and thrombectomy are often recommended now on a case-by-case basis. So I'll stop there and hopefully we'll have some time for Q&A. Thank you very much.